The race is on to reduce the number of needless amputations related to peripheral artery disease, which is a narrowing of the arteries in the peripherals, mainly the legs, due to plaque buildup. One area of research is around diagnostics and striving to improve the indicators which lead a physician to believe amputation is the best option. Jill Sommerset is one of several clinicians who released new research in April that analyzes the use of pedal acceleration time as a reliable, non-invasive predictor of limb salvage. Jill is a registered vascular technologist and technical director with Peace Health Thoracic and Vascular Surgery in the state of Washington, and she's here to discuss the study, Pedal Acceleration Time, a novel predictor of limb salvage. Jill, thank you for being here.
And thank you, Kim, for the opportunity to be here with you.
So let's first define pedal acceleration time, how and when it's used.
So pedal acceleration time, or PAT, is essentially the measurement of the arterial waveform in the foot. It is measuring the onset of systole to the peak of systole of that waveform. And we've used acceleration time in other beds of the body, such as the renal arteries, the carotids. We're now applying it to the foot.
So how does it compare to other non-invasive arterial testing, such as the ABI or TBI or other diagnostics? Where is this gap in terms of the results and what they tell you?
Well, as we know, ABIs and even TBIs have been around for decades. It's really been the standard of physiologic testing. But in the diabetic patient or renal failure patients, especially ABIs can fall short because these vessels are now filled with calcium and that test becomes erroneous. We then
they can actually get a false normal, especially in those, the ankle brachial index, the ABI test, which is the blood pressure cuffs on the arms and on the legs, and they measure the differential between the two.
Yes, that is correct. Yes. And it is reliable in the non-diabetic, non-renal failure patient, but there is this gap of testing. We then look to the toe pressure, or the TBI, which is a sensor that goes on the tip of the toe, and we can analyze a waveform and get a toe pressure. And that is a great test. However, if there is no digit or if there's extensive tissue loss, that test can also be very limiting. So there's a big gap in testing for patients with chronic limb-threatening ischemia, or CLTI.
So what was the catalyst for you and other clinicians to actually put together a paper on this, and what's the purpose?
So 4 years ago, I decided to scan my own foot and analyze, get more information, because I was very frustrated as a vascular technologist that I couldn't provide more information. So upon scanning my own foot, I realized that I could see the arteries in my foot. And we began researching this and looking at waveform analysis, ratio, velocity, and ultimately acceleration time was much more sensitive. And then we started to correlate it with reliable ABIs because we needed to compare it to something. So our first initial validation paper is looking at 499 limbs. All of those patients were non-diabetic, non-renal failure patients, and we found a statistically significant correlation between ABIs and PAT. But PAT actually correlates very nicely with clinical symptoms. So that's where we started, and now where we just published that PAT is a novel predictor of limb salvage, because now we're analyzing the entire pedal arch. Not only looking at perfusion, but we are understanding now the anatomy and the flow direction of the foot. We've essentially unlocked this new perspective of the foot, which is so helpful in these very complicated patients that are facing possible limb salvage or amputation.
Can we go through a little bit of the study and maybe some of the patients? Maybe were there any surprises that you discovered?
Yeah, so this recent publication, we analyzed, it was a retrospective review of 73 patients that were diabetic, and they all had infrainguinal disease. So we excluded the patients with isolated iliac disease. We also excluded patients with a Wi-Fi infection score of 3 and 4, or 2 and 3, excuse me, because we needed to deal with that in a source control manner. So when we looked at our patients, they all had a PAT of class 3 or class 4, indicating significant disease. 80% of those patients underwent endovascular revascularization, and 20% underwent open bypass. And we found that patients that had an improvement in their PAT post-procedure to class 1 or class 2 underwent limb salvage. And unfortunately, those patients that did not see an improvement out of that class 2, 3, or class 4 classifications, they unfortunately underwent a higher level amputation above the ankle.
And would you consider all of those, based on your study, would you consider now all of those ones that did in fact go through amputation as legitimate, or are you concerned that maybe some of them might have been needless?
We felt legitimate. We attempted multiple revascularization, and unfortunately, they were forced to undergo amputation due to maybe a bone infection or severe ischemia.
Is it possible that PAT becomes a standard protocol in determining the potential for limb salvage?
I think potentially it has a role, and especially in the diabetic renal failure CLTI patient. I think that's really where it's going to prove its value. We use PAT in all of our arterial diagnostic testing, whether it's for claudication or decreased pulses. But in the CLTI patient where there's wounds involved, we can go with the probe straight next to the wound bed and have a good indication of what the blood flow is like, whether it's direct or indirect to the wound bed.
So I get how this can be done as a general diagnostic, but how can this actually be applied interoperatively?
Well, I'd like to show you. I have a nice case example. Again, we use PAT not only preoperatively, but through all phases of care. So during intervention, whether it be open or endo, revascularization, and then also throughout the course of wound healing. So here's a very good example of a patient who had presented with a foot infection of the left foot and underwent source control. You can see there's a below-knee amputation on the other side. And this patient had class 4 PAT to the wound bed, and you can see this waveform here in the foot is very low in velocity and delayed. And so this is where my probe would be sitting throughout the procedure. And this patient has one vessel feeding the entire foot. And with just treatment of this one vessel to the foot, we saw a tremendous change in the pedal acceleration time, nearly to class 1 PAT. And again, this is real time on the table changes that tell a physician, have we done enough? We are targeting the artery that goes right to the wound bed. So this is quite an exciting space to develop and discover more and more as we face these challenging interventions.
It's really interesting because the X-ray technology they use in these angiograms, it gives you a 2D image of a 3D leg, right? And so it's one thing to actually increase the flow in the main artery, but the question is the body actually using that increased flow? Do we have increased perfusion? And that's what you're saying that this could help provide in a real-time fashion to help a doctor know, well, do I need to do more or could I do less, or less is more?
Yes, that is correct.
What's amazing to me is you're just literally using a device that every single office has already. You're just advancing its use case compared to, I mean, they're already doing it in other areas, from carotids, as you mentioned, and the renal arteries, and they're using in other areas.
That is true. And we just took what the technology that we have today and are applying it. However, there are some limitations. If you do not have an updated ultrasound system, you may run into limitations, such as the scale of the waveform, because these velocities in the foot can be quite low. If the velocity on the ultrasound system doesn't drop below 10, that can be a limitation. So you do need an updated ultrasound system to be accurate.
So is every technologist skilled in doing this? This is something that the doctor can just say to the tech, hey, would you mind checking the pedal acceleration, on this particular, patient?
I think in the future, it's going to be a standard of care. But right now, like everything, it has to be something taught. And we have to have a good understanding of how to apply the technique, how to find the vessels in the foot. So there is a learning curve that we all need to be aware of, so the test is done properly.
Have you faced any resistance, any pushback? I imagine I was looking at your LinkedIn profile, when you posted it, it seemed like there was a lot of positivity around it. Have you faced any resistance or pushback or concerns about it that people have wanted you to address?
I think all valid concerns, which is we need more research, and that is perfectly acceptable. We absolutely understand that. We need more research around low cardiac output, how it relates to, when there's severe congestive heart failure. But, there's a lot of excitement around this new technique because it really provides an extra piece of information that really could help save a limb in a lot of situations. And we found that in our own patient situation where maybe the TCPO2 read as abnormal, indicating that a patient should have an amputation, but PAT proved differently. And so this is a very exciting data point to compare to other diagnostic tests.
But you're not saying to these doctors, hey, use this to make that determination right now. I mean, you're just saying, hey, add this to your toolbox. And what harm does it do to just go ahead and perform it? Is it that much extra in terms of time and resources to perform this? Or is this something that can just be added in with no harm, no foul?
You are absolutely right. It is, again, non-invasive duplex ultrasound. It takes an extra 10 to 15 minutes to keep scanning down the leg to the foot and obtain these extra values. And we are suggesting that people shouldn't change their practice, just add this extra data point so we can evaluate the patient with more information.
And the doctors, the pushback I get on several tests, especially with blood work that I ask them to perform for patients, is they say, well, I just don't know how to understand the results. Once again, can you give us a clear indication, hey, doctor, based on what you find with this data point, here's what you may know.
Mm-hmm. Yes, and I think that's the beautiful thing about PAT is it's an actual number, and it resonates with patients, with all providers, and it gives you something to strive for. We now know that the PAT number should be less than 180 milliseconds in the foot to predict limb salvage. And when you can tell a patient that they went from 250 to 120, that's phenomenal. And then especially if you put someone on a walking program for claudication and they come back in 6 months and their numbers have dropped, and that shows that they have built collateral flow. So the understanding of the use of PAT is quite deep, and there's a lot to teach. So we're getting there. There's just not enough time in the day to write papers and publish, but I think it's quite an exciting.
Well, patients are always asking, hey, I'm walking. You tell me to walk, doc, but how do I know if I'm really doing well? I mean, above and beyond the ultrasound, is there some other indicator that can tell me that what I'm doing is actually working? Do you think that this is going to be that data point that patients will even use as their own indicator?
Oh, absolutely. We have a third-year medical student. We did a little pilot study looking at patients who are still continue to smoke, and we just put them on a walking program. They had an ABI of around 0.5 or 0.6, and with smoking cessation and a rigorous walking program, we watched their PAT drop almost 2 categories and become asymptomatic, because PAT helps capture all of that collateral flow in the foot, and it is an amazing marker for them to continue to exercise.
Is there anything else that you want to add? You do have a few slides that you might want to share.
Yeah, just so the audience can see what this looks like. So pedal acceleration time is not only measuring the acceleration time of the arterial waveform, but we have this new amazing look into the foot now with duplex ultrasound. We can quantify perfusion. We can understand the anatomy, especially if there's anatomical variations. And we have the technology to understand flow direction in the foot in the setting of significant arterial disease. And as you can see in this photograph here, this is a patient with bilateral forefoot amputations, and she's been revascularized, and we are following her perfusion to the foot throughout the course of wound healing. She is diabetic, so ABIs were not reliable. And of course, she has no toes for toe pressures. And so this is an easy, non-invasive test done at the bedside. And this is a representation of acceleration time of this arterial waveform, measuring the onset of systole to the peak of systole to obtain an acceleration time. And as you can see in these complicated patients, the beautiful thing is you can put the probe right to the edge of the wound bed and have a very good understanding of what's happening in the limb. And so this is the view that we can see with ultrasound. This is an oblique view. Our protocol is to obtain a PAT in all 5 sites of the pedal arch. And with duplex ultrasound, you can see we can image these vessels quite well here. This is looking at the top of the foot, and it correlates nicely with angiography. And here's a representation of a patient who really benefited from PAT or advanced duplex ultrasound of the foot, because these patients are complicated and they went on for complete wound healing with a normal class 1 or class 2 PAT. And then we can image the bottom of the foot. We have a very good understanding of anatomy, and we've correlated this with angiograms. And again, the use of ultrasound with follow-up surveillance in these complicated patients. So, there is a learning curve to understanding pedal acceleration time and measuring. So we're trying to teach proper technique for the diagnostic accuracy and the utility of this tool.
Have you ever thought about this or been asked this, hey, if this was something that is truly beneficial, wouldn't you think someone would have done it before? Why you? Why your group of researchers now versus before?
That's a good question. I think it's passion, it's curiosity, and really the desire to help our patients. I help run our limb salvage program at Peace Health, so I'm very invested in helping these patients decrease the rate of unnecessary amputation. So maybe it was just, again, curiosity that led to this nice discovery.
Thank you so much, Jill Sommerset. We really appreciate all you're doing to help save life and limb.
Thank you so much.